To turn it over to our founder, Dr. Randall Maxey.
Thank you so much, Dr. Barbara David Stevens. Welcome, Dr. Ivan Walks, my personal psychiatrist, and Dr. Hines, and also Ms. Romero, and all those who've chosen to join us for today. Today is significant for a number of reasons. Number one, I get to present uh, a person who's responsible for me advancing in medicine in ways that I did, Dr. Richard Williams. I'll introduce him in a second. But also very important that we know that there's a move afoot to have Marcus Garvey exonerated posthumously. Uh, and he was a Black man, a Jamaican man, who proposed to take many of our slave brothers back to their homeland. And he was uh, downtrodden by our government because of that. But even more recently, we know that we are right on the celebration of Black History Month, and in particular, the anniversary of Dr. Martin Luther King, who I had the pleasure of meeting as a freshman student in 1959 at Miami University, and later and Ivan, he was my fraternity brother in Alpha Phi Alpha. I met him at Howard University, and he was an amazing man. And I was extremely disturbed and hurt when white racists chose to assassinate him. That's another topic. And I got emails recently about it's very important that as events come up on January the 20th and that we celebrate a king and not a felon. But without further ado, I'm going to ask Dr. Richard Williams, cardiologist, and he's one of the few physicians that have people thinking a PhD is the highest level of academic honor. It is not. It's called a Doctor of Science, or an SCD. And Dr. Williams is an MD. He's a fellow of the American College of Cardiology, but he is also an SCD, a Doctor of Science, and that is an honorary title given to the highest level of accomplishment, such as Albert Einstein, Hawkins, and a few others. And Dr. Williams is going to speak to us about why high blood pressure is so dangerous to African Americans. And he is an accomplished academician. I would call him also a sociologist as well, but he is a true Renaissance man. Dr. Williams, please address us.
Thank you, Dr. Maxey. Can you hear me well?
Yes.
And can you also see me? Okay.
I think so.
I'm not sure that my thing is working well. Can I be seen on screen?
Yes, sir, you can.
Okay, thank you, Doctor. Um, I want to reemphasize something that Dr. Maxey mentioned, and that is the exoneration and pardon that President Joe Biden extended to Marcus Moriah Garvey, who was a hero and a champion of blacks back in the 1920s and was imprisoned for his work in trying to uh, uh, inspire Black people in general, but especially in attempting to uh, start the Back to Africa movement. He was in prison for 7 years before that on the trumped up charges. I use that term advisedly, trumped up charges of mail fraud. And so Joe Biden, just one day before the end of his term, extended the pardon that came about today. And I want you all to know that many Black physicians, in particular, were responsible for bringing this pardon about. I was one of them who worked with people in Congress, particularly uh, Maxine Waters and also um, a number of other representatives who fought for this to occur. So this is a very significant day for that reason, and also for the reason that we're celebrating Dr. Martin Luther King Day tomorrow, unfortunately on the same day that another auspicious ceremony is to take place in Washington. So with that, let me begin what I was asked to do. I'm addressing an issue that came about this past Friday, the 17th of January, in which CNN, the largest news outlet in the world, published an interview by Dr. Liana Wen, who is an emergency room physician and former commissioner of health in Baltimore, Maryland. This paper was published and an interview was given on CNN regarding the nature of hypertension or high blood pressure. The reason that this is coming up now on this program is the way that that interview was carried out. She gave a good description, basically, of what high blood pressure or hypertension is, but it wasn't what she said, it was what she didn't say that was very important. I think everybody on this program knows the importance of hypertension to the Black population, that hypertension has greater incidence, prevalence, and mortality in the Black population. And that has been recognized for a number of years and has been emphasized by a number of Black organizations, including the ABC, the Association of Black Cardiologists, the National Medical Association, the Association of Black Women Physicians, and on, and also the Minority Health Institute. So there is no secret that we suffer more from hypertension than anybody else in the world, and that if anybody is going to be talking about that subject, they certainly need to put that fact into the mix. However, not one single word was mentioned about hypertension in Blacks in that interview, which ran for some time. That is somewhat odd, you might say, that someone would not mention hypertension in Blacks in an interview and in a paper that deals with that subject. But I think you need to understand what is happening at this particular time in regards to what I call a whitewash, and I use that term advisedly, Dr. Ivan Walks, a whitewash of what we have tried to accomplish in eliminating healthcare disparities over all these years. It is important, especially for people who are listening to this program and others, to recognize the fact that there is a big pushback against our advances in DEI and diversity, and in recognizing the importance of race as a construct that deals with disease processes. Dr. Maxey and I go way back in the history of this, because back exactly 50 years ago, this book was produced. I was the author. It's called The Textbook of Black-Related Diseases. And in that book, we emphasize the fact that, among other things, hypertension or high blood pressure is a disease inordinately suffered by Black people, and that we needed to take certain steps to do that. And in order to take those certain steps, we had to make people aware of the fact that they are victims or are going to be victims of hypertension. I produced another book, my 9th book, just 4 years ago, which is called Blacks in Medicine. And it re-emphasized this whole point about hypertension in Blacks as well as other disorders. And it called hypertension one of the 5 major problems that Black people, medical problems that Black people suffer in this country. So why is it that we now see this major news organization, CNN, producing a program on hypertension, which mentions not one word about hypertension in Blacks. I think it's something that might be designed. This is not something that is occurring, in my estimation, by accident. I think it is a thinly veiled attempt to push back against the advances that we are making in regards to recognizing and creating awareness about diseases that affect us. And that's why I use the term whitewashing. The power structure and especially the media are attempting to clean us off the map from the standpoint of recognizing the importance of diseases that occur in us so that they don't have to be worried about Black people dying or Black people getting sick, and particularly spending a lot of money on healthcare for Black people. If you think that this is something that I'm just dreaming up, take a look at the statistics that are occurring around the country in regards to the pushback against recognition of these things, against being woke, against DEI, against diversity. 10 states in this country have already passed laws outlawing DEI, and that includes Texas and Florida. And I believe that Tennessee may be included in that count as well. And there are also several companies which have dismantled their DEI programs, including most recently Walmart, the world's largest commercial company or supermarket, etc. So think about it. Think about what's happening to us, especially at this auspicious time when we're about to go into a new chapter. Some people might say into the winter of our being of political measures, etc., with what is going to occur tomorrow, the inauguration of the 74th President of the United States. Bitter words coming from my mouth. I hate to be able to even saying that, have to say that. But in any event, that's the topic that I wanted to bring to your attention. And I'll stop at this point and see if there's any discussion or any questions or whatever that anyone would like to raise on this issue. And then I'll come back and give some recommendations for how this needs to be addressed.
So Dr. Williams, I certainly appreciate you, and we're honored by your astute presence at this time. A major concern that I have, being a nephrologist and treating so much hypertension and the sequelae thereof, is why does it affect Black Americans in a different way? I understand that sometimes it's earlier in life, it's often unnoticed, but what are some of the discussion points around why it's so dangerous, in particular for African Americans or those of African descent?
Well, I will address that by kind of deferring the answer to Dr. Ivan Walks, because I think that this is something that falls within the realm of societal sickness and pressures and stress that come within the province of psychiatry and psychology. I think, in other words, hypertension to a large extent that occurs in Blacks or African Americans is largely due not to physiological causes, but to psychological and psychiatric causes. And I'd like to hear what Dr. Walks might say about that.
Just before he does, let me just also remind you, some research I did during my time working on my doctorate. Some research showed that if you were to do a biopsy of blood vessels of infants that were African American, that you would find that the cell walls of blood vessels were somewhat thicker and that the endothelium was thicker, suggesting early potential hypertension, and that these vessels were also more hyperactive than normal blood vessels in other people. So I believe that you're absolutely right. There are the social, psychological, and economic causes, but there are also some physiological bases of that. There are also a difference in the creation of the mediators called catecholamines, and in the pathway from dopamine creating catecholamines, there's a different constant that manufactures those at a different rate, but that's beyond the scope of what we're going to discuss today. Dr. Walks.
Let me start by saying, Dr. Maxey, that always, it's I usually say it's a pleasure, but I'm going to say it's an honor to hear from Dr. Williams. There is so much history, legacy, scholarship when Dr. Williams comes on to talk about it, anything with us. I'll start off because my senior psychiatrist, Dr. William Lawson, is there with his hand up. So before I say something that he has to correct, because he will, let me say this. I think that we have to take the opportunity to recognize both what Dr. Williams shared with us and the last comments you made, Dr. Maxey, and understand that when we say things are multifactorial, when we say things have multiple causes and all of that, it doesn't allow us to ignore any of the causes. So yes, babies' blood vessels may show a propensity towards a later ailment. Our society absolutely ignores some of the things that are important to our community. And so we have to look at both of those. And in the middle of it, we have to look at it's tough sometimes living where we live. It's tough sometimes dealing with what we deal with. And some of the research I did many years ago that was covered by major networks and all of that good stuff, and didn't really change anything because we know we've known what we've known for a long time, showed that living in many of our environments leads to actual mental health diagnoses. Living in some of these environments can lead to diagnoses like post-traumatic stress disorder, just like being in combat environments overseas can lead to those kinds of diagnoses and folks who have to go there. So I think I am never willing to jump on any of the bandwagons. I'm not willing to jump on the it's all hereditary and it's all medical bandwagon. I absolutely will not jump on the bandwagon that this is all about racism and it's all about, it is a combination of things, and to our peril, we ignore any of them. To our peril and missed opportunity, do we ignore the fact that our society gives us many opportunities to do better, and that our genetics requires us to pay attention and not to let anybody distract us with, well, if we had a different president, it would all be okay. If the FDA did something different, it would all be okay. If HHS had the right leader, it would all be okay. We have a lot of opportunity. I won't say personal responsibility. I will say opportunity. We have a lot of opportunity to do better individually and to do better in our community, while we acknowledge that if we vote more enthusiastically and encouragingly, that we can change some of the other things. So, Dr. Williams, I hope that gets at some of what you wanted me to get to. And I really do want us to be able to pull in Dr. Lawson on some of this because it is so important.
Absolutely. I'd love to hear from Dr. Lawson if we could.
Well, I think that in many ways that Dr. Williams, hypertension is one disorder that sort of supports your assumption that there's probably a tendency to keep that literature out of the public eye, because there's one disorder that is strongly tied towards the unique experiences of African Americans. It's been known for a long time that if you look at countries that have less differential. For instance, if you look at Nigerians before urban areas, their rates of hypertension is much lower than that of their predecessors, their ancestors who went to Africa. They came to the U.S. where the rates are higher. If you look at South Africa, the folks that live in primarily white environments tend to have higher hypertension rates than folks that live in the more rural areas, those that have very little contact with white folks. And if you look at the US, there's a colleague of ours, Dr. Jules Sorrell at Howard University in the psychology department, who's been working for years showing that the kind of exposure to institutional racism, stress, is related to high rates of hypertension. And the American Psychological Association has published a number of articles showing that strong relationship between our rates of hypertension and lifestyle, and particularly living in environments that have high rates of institutional racism. And then, of course, there's the evidence that that because of the one of the major causes of death and the middle crossing for many of our ancestors is the fact that many of the folks ended up becoming hypernatremic because one way to survive was to become sodium retainers so that when they got the country, they would survive. So we got the both biological as well as cultural, as well as attitudinal issues that converge together to lead to this persistent problem of hypertension among our folks.
Thank you, Dr. Lawson. You hit on a very important point to me, the so-called slave boat theory, which has a lot. And I think that person who advanced that was a previous colleague of Dr. Williams back at Martin Luther King some years ago.
Right, yeah, Drew Medical School, right.
Dr. Neighbor Stephen.
You want a comment from me?
Hard question. If Dr. Williams wants to continue.
I don't have a question at this time, but I do want to make a comment. Another one of those factors in this multifactorial issue is the quality, well, the access to healthcare and the quality of that healthcare that is rendered, which is to say, for various societal and economic reasons, the African American community is not as frequently has the ability to take advantage of appropriate preventive care.
Thank
And
you.
And then when they get past the prevention and they are at the point of having acute pathology, they may or may not have access to the appropriate care to manage the conditions. So I'm very concerned about access to care, and I didn't want that issue to get pushed aside. We are not accessing care for various reasons, and there are reasons to question the quality of some of the care that is accessed. And now, specifically around the issue of hypertension, that is a very important component. It has to be identified. It's known as the silent disease and the silent killer. So it's very important that you have that access.
Very interesting, Dr. Neighbor Stevens, that you mentioned that silent killer accolade title for hypertension, because that is exactly what CNN put on the program as a title, the hypertension, the silent killer. And here are the facts and so forth. I want to finish up my presentation by bringing us back to how we started, and that was a consideration of what this article and this presentation by CNN tends to do. I said that I think it's a whitewash, and I use that term advisedly. I think that what that indicates, or should indicate to people, is that in fact, all of our the importance of our uh, disease and illness problems, our struggles, the importance of all of that is being wiped away, being whitewashed. Uh, and I told you what I think the reasons are for that. They simply don't want to deal with this anymore. And this is kind of a surrogate, hypertension is, of one of the things that they are going to be uh, eliminating from their consideration. I often survey the literature, the medical literature, and there have been many articles published recently about why we should not be concerned about what is called race conscious medicine, that we need to think as though we are colorblind in regards to illness, that illness has no race and that race has no credibility. Uh, I want to make sure that everybody understands the nature of that reasoning. I have no problem with understanding that race is not a physical construct, and that all of the uh, criticism of race as a term are okay. But bear in mind that we are still Black people in the United States of America. And there are also people who are known as Caucasians or whites and other ethnicities. Uh, and that's a fact. You can't close your eyes to that. And there are diseases that seem to accrue to the presence of those different racial identities. And there are certain considerations that need to be given to that. So with hypertension, we have to recognize the fact that, as Dr. Maxey said, there may be different causes and different things that need to be done to address those causes, which are peculiar to Blacks as opposed to others. This is something that we have thought about for a long time. Apparently, there are a number of people who think that we need to get away from that, and that, as Dr. Waltz said, that doing something like that may be to our peril because of the fact that we're only cutting off our noses to spite our faces if we think that we're going to eliminate a problem like hypertension by simply not considering one of the several possible causes and dealing with them. So I'll end by simply saying, keep your eyes open, make sure that you recognize what is going on in this medical universe in regards to dealing with problems that uniquely or particularly disproportionately affect us. And hypertension is one of the biggest ones of those issues. We cannot let people simply walk away from high blood pressure or hypertension as something that affects us and say, well, this is a colorblind situation, and we will not deal with it on the basis of race and ethnicity any longer, because that's what CNN is attempting to educate people to. Thank you very much.
No, thank you so much, Dr. Williams. And we have other contributing faculty members, or moderators, including Ms. Romero. I think she got kicked off a minute ago. I don't know if she's back or not.
Yes.
Ms. Romero, you have a comment or a question you'd like to address to Dr. Williams?
She's on mute. We need to.
I
There we
do.
go.
Hi, Dr. Williams. Good afternoon.
Good afternoon.
It's a pleasure to be participating with this event with you today.
Thank you.
I have a question as a nurse. Healthcare, the approach to healthcare, particularly cardiovascular disease, is a much more collaborative experience in the hospital. How would you advise me as a nurse trying to advocate for my patient when I feel that my patient's healthcare needs are largely being ignored as a Black patient by non-Black healthcare workers that are telling me or telling the patient that their blood pressure is normal for them, and it's not being addressed?
I think that that's a very pertinent question and issue. And I'm sure that you've seen a lot of that in your experience. And that's why you're asking this question. Uh, your father knows the best answer to that, of course, which is I think you need to address the patient on this and make sure that what you observe is transmitted to the patient and have the patient bring these issues up to the doctors. The other thing is that we need to revisit the issue of concordance in medical care with the smaller numbers of nurses and doctors who are Black that we have and who are treating Black patients as opposed to white uh, practitioners. Uh, we need to recognize the fact that Black patients get a great deal more out of the treatment and get greater access, to use a term that Dr. Neighbor Stevens mentioned, when they attempt to be treated by Black doctors and Black nurses, as opposed to whites. And that is a fact that has been documented repeatedly. And your father, Dr. Maxey, knows that full well. So I would suggest that you ask him more about that and that you go to your patients and address them directly. Tell them that they need to ask those questions of their doctors. Always ask the doctors, why are you not considering this and that in regards to me? Because I heard from Dr. Maxey that I should be considered something special in regards to this disease that I've got.
Dr. In true normal fashion, let me throw this question back in your lap. There was a study done some years ago called the CAFE study, and they treated individuals with a combination of diuretics and something called a beta blocker, and they obtained very good blood pressure control. They treated another group with calcium channel blockers, and I believe a renin-angiotensin agonist, and they both created absolute control of blood pressure. But they found out that the life of those treated with the diuretic and the beta blocker was not long. The survival, even though the blood pressure was equal in both groups, was with those patients who were treated without the beta blocker, without the diuretic, but were treated with what's called an RAAS inhibitor or a calcium channel blocker, suggesting that we need to look at how pharmacologically and with what type of medication we treat patients that happen to be African American. I wonder if you'd comment on that, and I think that's relevant to to Ms. Romero's comment that all medicines are not equal to all people.
I can comment on that very easily by flipping that right back in your lap, Dr. Maxey. I believe that study came out of Columbia University, and I believe that one of your mentors there was responsible for that. Is that correct?
John Lehrer.
Yes. Uh, and I think that you're in a better position to give an answer to that than I am, but I'll simply say that kind of parroting things that you have written yourself in my books and in others about differences in reactivity to certain medications by Blacks and whites, that there is a difference, and it is well documented. For instance, that beta blockers not only may not have an idealized effect or impact on patients who are Blacks as opposed to whites, but it may also have a detrimental effect. So that's one of the findings of that study and other studies going forth.
And
So
the other
what it
comment
comes
that
down to is that there is a difference in the impact of certain medications depending on the patient's race and ethnicity.
so the other thing that Ms. Romero brought up, and I'll yield forward to that, is that many times when African American patients are treated by doctors who are not culturally and sometimes not clinically competent, they say, oh, your blood pressure is supposed to be higher than what we consider normal because you're Black. And that's a very major disservice they're doing to those patients by saying your blood pressure is all right, even though it's 180 over 100. They give us misinformation. I'm very concerned about that process. So I thank you for bringing up that. So we have any other comments?
I have as per usual, Dr. Maxey, I have a couple of comments. I I wonder how, as we are giving information to folks, we say that we can in some ways accept race as being a construct and not an actual thing. But then we talk about how certain races, and particularly African Americans, have a higher incidence of this or that. I think maybe it needs to be one or the other. Maybe we have to talk back when folks say race is not something real, if we're finding real differences in how we treat people. So
Exactly right.
can we
Exactly.
can we take a stand? And then the second comment that I want to make, just before you cut my microphone off, Dr. Maxey, let me also say this. I've I've been around a couple of years now, and I have seen that the opportunity for us is to not only make sure that we have African American patients, Black folks treated well, but the opportunity is also there for us, knowing that we don't have as many Black docs as we need to treat all the Black folks, that we make sure folks who are willing to treat us fairly and folks who are willing to understand that we are humans and we are people that deserve and have earned respectful treatment. Let's not put them off by saying because you're not Black, you can't work with Black people. I know nobody has said that,
Dr.
but I
Walker,
think that that's a potential implication
I
from some
think
of the
you're making
conversations.
a great point, and I want to say that yesterday I came home and I was very happy that I got some maple syrup from New Hampshire from a special friend. Uh, and the difference in this special friend, he is what I call culturally and clinically competent. And I think it's not whether you're white or Black, but it's how your training and your heart is. And I also think that something that we haven't done, I wrote an article some years ago about individual medicine, personalized medicine. And we looked at what makes our so-called racial definitions right or wrong. And I think we need to come up with something that you're suggesting now, that we define people on different bases. And that may be the basis of how they metabolize in their body. And I do know that in people with high blood pressure, they have something different called the Michaelis-Menten constant. That's how they generate the catecholamines that cause high blood pressure. And if we define people on biological basis and not just a construct of whether you're Black or white, we'll be closer to dealing with precision medicine. And just as an aside, we know that those same hormones that create catecholamines, ultimately, if we continue to oxidize catecholamines to get rid of them in the body, the end product is called melanin, and that suggests color. So not just color, but we have to look at the inside workings of God's human body. And I think you're absolutely right, Dr. Walsh. And I love my syrup from New Hampshire.
Dr. Maxey, we have a very relevant, well, we have two relevant questions, but the first one is very relevant. And that question is, what is normal blood pressure readings? And the second question is about whether or not metoprolol, let me make sure that's the one. Yeah, metoprolol is a beta blocker.
Would you like for me to answer those?
Yes, Dr. Williams, please.
All right, the first question, answer to the first question is that the most recent definition of hypertension is a blood pressure which is above 130 systolic, I'm sorry, above 120 systolic and 80 diastolic. Now, 130, if your blood pressure is 130 or above, you are absolutely hypertensive. That's as opposed to previous definitions, which allowed blood pressure to soar as high as 140. So about 3 or 4 years ago, there was a redefinition of what hypertension is. So the bottom line is that we want to see your blood pressure at 120 over 80 or lower. The answer to the second question is about metoprolol. Metoprolol is a beta blocker, and it's a specific beta blocker. It blocks what we call the beta 1 receptors in the heart and blood vessels.
Dr. Williams, you sent me a slide a few months ago that showed if you were able to obtain a blood pressure of 120 over 80, that it would extend your potential of life and would decrease certain things like strokes and heart attacks by more than 60%. Maybe you can comment on why that obtaining an ideal blood pressure is so important to survival.
That's a difficult one to answer. We know that it's factual, that basically the lower the blood pressure down to a certain level, the better it is for you. And there's a certain benefit as far as longevity is concerned. That was determined quite a long time ago, and it seems to be the case continuously. More recently, with the redefinition of what hypertension is, those facts were used to verify that the practitioner needs to drive for those blood pressures that we mentioned in order to not only avoid the complications of hypertension, but also to potentially lengthen life.
Thank you so much. Are there any more comments or questions in the chat, Dr. Neighbor-Stevens?
Not at this time, but Dr. Lawson has his hand up.
Dr. Lawson.
Just want to note you getting back to the issue Dr. Walks was doing in terms of how you define race, and there's been a lot of historically, there's been a lot of discussion, especially among anthropologists and others. Part of the issue is there's two questions. One is, are biological differences important? Yes, because often it was a distinction between whether or not any of these changes are biological or not. But then the other question is, if there are biological differences, do we group people by clusters of them? Or what clusters are meaningful versus not? If you remember in the US, our cluster is that one drop of black blood, dark skin, defines you as a certain race. It doesn't make sense. So it's much more, actually, it's much more complex than that, especially when we did work in terms of folks who Ethiopian ancestry, found that there are certain groups that had skin color that was not necessarily related to other changes in the body, and so he couldn't predict it. And the other point you're making in terms of what determines whether or not certain drugs are effective or not, and we certainly know among psychotropic agents that is not simply metabolism, but also receptor activity, as well as the extent to which the agent is made available, some of the differences that show up in terms of distinction between so-called brand name medications and generic agents. So it's not just that the agents are similar in terms of metabolism, but whether or not the and the availability of the agents are important. That's really showing up in some of the psychotropic medicines we have now today, in which we're getting some very similar receptor activity with very different metabolic activity, so that you have drugs that have very, very different bases of actions, and also maybe a whole different way in which they're relating. And this is also beginning to show up in terms of treatment for Alzheimer's agents. That is that no longer talking about that with metabolic activity, but we're also talking about receptor availability, as well as the extent to which they cross the blood-brain barrier.
Well, thank you, Dr. Lawson, so much. Dr. Williams, this has been a great and insightful discussion. Wonder if you have any final thoughts about this and any other area that you want to speak about. I'm so happy to have an SCD on the phone, on the Zoom call. This is rare.
Dr. Maxey,
Yes.
do not ask Dr. Williams if he has any final thoughts. We want him around for a long time. Ask him if he has any concluding comments, please.
Well, thank you for correcting me, Dr.
My
That-
concluding comment is that we need to be more cautious as we move forward into this new year, not just looking for wildfires to pop up as they have, of course, in Southern California, but for other dangers that are lurking and are about to be sprung upon us. And I think that we are, it's not by accident that we're having this meeting today and we're discussing these issues. This is a prelude to some awful things which may happen, and we are given the opportunity to think about what may happen outside the box, and perhaps to take some preemptive steps now rather than waiting until these things are visited upon our heads.
Well, thank you so much, Dr. Williams. Concluding thoughts, Ms. Romero. Let's start with concluding thoughts with Dr. Lawson, then Ms. Romero, then Dr. Wonks, and Dr. Barbara Davis-Stevens. Dr. Lawson. Is Dr. Lawson unmuted?
Not yet. Dr. Lawson, you're still on mute, sir.
While he's unmuting, we have another, I think, important question in the chat, and that is, Ms. Hall wants clarification. Do I understand correctly? Beta blockers are not recommended over calcium channel blockers for African Americans.
I can answer that question very quickly. Again, referring to the most recent revision of the hypertension guidelines that came out about 4 or 5 years ago. There was a particular section that dealt with hypertension in Blacks and how they should be treated, so to speak. The recommendation basically gave a stratification of treatments for hypertension, beginning with lifestyle alterations and dietary observations and so forth. But then as far as medical therapy is concerned, using medication at an appropriate time, it was felt that hypertension in Blacks should probably start with at least one medication, but possibly with 2 medications in combination. Most likely best with a calcium channel blocker combined with a diuretic. It did not rule out the possibility of using beta blockers, but put essentially beta blockers at the second tier or even the third tier of treatment. So if one were to treat a patient with hypertension who is Black initially, after finding that there was no response or not a good response to the non-drug treatment, one would start most likely with a combination of of calcium channel blocker and diuretic. It is possible, of course, to start with just one medication, but the recognition is that Black patients need a bit more to forestall complications which might occur. And therefore, the two-drug regimen was recommended. This is also something that was recommended by the International Society on Hypertension in Blacks, which is now defunct, but for a long time looked at the treatment of hypertension in particular in Black patients.
Yeah, and I also want to add that a beta blocker is entirely appropriate in people with certain orders of rhythm and rate, heart rate, and after myocardial infarction or heart attack. I didn't say that it can't be used, but usually it's in combination with the medications that Dr. Williams was speaking about.
Yeah, we don't want anybody to stop taking beta blockers because of what you heard today. Beta blockers are certainly indicated in certain situations. We're talking specifically about hypertension, and as you know, that's very rarely isolated as one disease process is usually combined with something else or causing something else. And you often will find beta blockers being used in combination with other medications.
Thank you. Concluding thoughts, Ms. Romero.
I would just like to add, in addition to advocating for my Black and Brown patients, educating patients at every level of healthcare, including prevention, acute care events, and also recovery.
Wonderful.
Thank you so much. Dr. Ivan.
Did we get Dr. Lawson's concluding comments?
Oh,
No, I thought we started off there. Go
Dr.
ahead.
Lawson?
Yeah, very quickly, I just want to note that this kind of discussion that we have here today, unfortunately, is not the kind of discussion that's often made in terms of drug development, marketing, and treatments. Thanks to folks like Dr. Williams and yourself, Dr. Maxey, we're having these kind of discussions with hypertensive medications. We don't have them. We have a whole host of other medications. And as a result, what we're seeing is that even though we are developing new treatments, they're just not very effective in our community like they should be, because the developers, the marketers, and everyone else simply do not get the input of people who treat Black people. So there is a major problem that we need to be able to be involved all along the whole development process of our treatments. I'm tired of listening to folks who say, you know, if you eat a salt-free diet, hypertension will go away. I'm tired of listening to folks say if you go out in the sunshine on Mondays that you're cured of every known disease known to man. I'm tired of listening to folks saying that this is a medication that affects one neurotransmitter system, but heck with all the other. We are like any other living organism, very complex, and we need to have people who are experts in terms of the intricacies of how our bodies interact with their environment, psychological, sociological, and physiologically.
Thank you so much, Dr. Lawson. Ms. Romero, did we
Yes.
get your comment?
Excuse me?
I think we're at Dr. Walks. Where we're at with our final
We are
concluding comment?
Dr. Waltz, and then Dr. Neighbor Stevens, and then Dr. Maxey. Dr. Maxey, look, let me use this time to make my closing comments. Dr. Lawson just talked about the importance of the right people being in the room when a lot of decisions are being made, particularly decisions about medications. Ms. Romero talked about and got great advice from Dr. Richard Williams about advocating for her patients. I want to take all of that back to our dear friend, Dr. Wilbur Jordan, who encouraged, when Dr. Jordan was regularly with us on Black Health Trust, Dr. Jordan, God rest his soul, talked about the importance of having that primary care doctor that primary care person. And I think we have to have someone, whether it's a nurse practitioner, a physician, someone who will try to translate for us all the complex new guidelines. I remember being told a long time ago that, your blood pressure the top number should be 100 plus your age. I don't know if anybody's old enough to remember when folks were advised that.
Yes,
That was wrong.
that's
Okay.
correct.
It's wrong now, but it changed over time. So I just think that it's important for us to remember the advocacy role of healthcare providers, healthcare professionals, the education role, putting things in plain language for folks to understand of healthcare providers and healthcare practitioners, and then the critical need to find someone who is going to treat us like a human. Please, Black folks are people too. Black lives matter. Black fathers matter. There's so much about us that is rich and enriching. And so I just want to say, I love Dr. Jordan so much for his clarity about the importance of that primary care advocate, that primary care person that would care about you and try to do the best for you.
Thank you, Dr. Walsh. Dr. Barbara Neighbor Stevens.
Thank you, Dr. Maxim. My final comment is to, and this isn't because I have a chip on my shoulder about this, but I want us to not forget that hypertension is not a disease that only occurs in people over the age of 21. And a lot of the research is indicating that a lot of the many factors that we talked about may be playing a role in additional ones, but I want to urge parents to remember that, especially if they are Black parents, that they need to discuss hypertension and whether or not their child has it or is at risk for it, because they are.
Well, thank you so much. I want to take a point of personal privilege and give Dr. Neighbor Stevens a charge. You introduced me some years ago to a young man that had been sending me syrup and presents from New Hampshire. I've never met him. I want you to have a dinner and host me and Ken somewhere in Nashville or Florida in the next year. I appreciate
Well, we'll see if we can make that happen.
so much. The other thing I'd like to say for next week, we have a wonderful presentation on the health concerns of ultra processed foods. You'd be surprised how this fits into the narrative that we've talked about for 4 or 5 years, and how these types of foods can negatively affect your health and how we can avoid them. It's going to be given by Ms. Gwen Moore, who has 2 master's degree in nutrition. But not only is she a nutritionist, but she deals specifically with live food and how we should eat that. So tune in next week for that. I'd like to thank again.
Maxie,
Yes.
since you introduced another topic, I feel emboldened to make a comment about something that I wanted to make a comment about. I'm so proud of the work we've done in encouraging our audience to be informed. There's something brewing that I think we all need to keep an eye on. And of course, I'm always going to push the issue of making sure your sources are reliable. But we have had at least one human to die of avian flu in this country now. And this week, they had to shut down the poultry industry in Georgia within I want to say, a 60-mile radius of Atlanta, because of the presence of the finding of avian flu in that poultry industry location. So, and I also saw an article this week that said something to the effect that having your flu vaccine may in fact be beneficial against avian flu. So what I am trying to suggest is that as we saw things beginning to come out regarding COVID, it is possible that we're beginning to see things evolving with avian flu. And I would encourage everyone to keep an eye on that topic.
Well, thank you, Dr. Neighbor. The only thing
Thank
is
you.
you're always bold. You know, you don't need to be emboldened. And I'd like to thank Simon for his wonderful work and helping us get this done. Have a great day, everybody. Have a great Sunday, and thank you to all the co-moderators. Have a great day. And Dr. Williams, thank you for joining us.
Thank you.
Thank you.
Good day, everyone.
Bye-bye.